This podcast represents the opinions of our hosts and their guests only. The content here should not be taken as medical advice and is for informational purposes only. And because each person is so unique, please consult your healthcare professional for any medical questions. Welcome to Once Shattered, Picking Up the Pieces, a podcast devoted to changing the way eating disorders and mental illness are viewed in our society. With your hosts, Jack and Linda Major and Ellen Bennett. Today's guest is Dr. Jeffrey DeSarbo. Dr. Jeffrey DeSarbo is a neuropsychiatrist and eating disorder specialist who draws on decades of clinical experience to examine the realities of modern-day eating disorder treatment. His insight on the evolution of ED treatment is derived from working at all levels of care, including hospitalization, residential, PHP, IOP, and private practice. He discusses the evolution of treatment professionals, treatment centers, the expansion of virtual care, the insurance and monetary climate, and the increasing pressures placed on patients, families, and clinicians alike. Find more about Dr. Jeffrey DeSarbo on his website, bucketlistdoctor.com.
Welcome, listeners, to Once Shattered, Picking Up the Pieces, episode 151. Dr. DeSarbo, Unfiltered, an eating disorder discussion from a veteran clinician about the things we don't say out loud. Welcome, listeners. It's great to be starting our 6th season with you.
Oh, welcome, everybody. It's great to be back. Amazing 6th season. And we're so appreciative to all our guests in the past and people coming up in the future, and for all you listeners who keep asking and listening to our podcast.
So exciting to have this conversation because there is an evolution that's happening, and what we've seen over the past 10, 15 years has been a dramatic shift from so many of our experiences. So welcome.
So we have an incredible guest with us today. This is an important, unfiltered, honest discussion about eating disorders and the realities of modern eating disorder treatment, what is working and what is not working so well. I must also mention that our guest, Dr. Jeffrey DeSarbo, recently published an uplifting and inspirational book with his son, Lucas. It is titled The Neuroscience of a Bucket List, Getting the Most from Your Brain and Life. And it's meant for anyone to help people live a more purposeful, joyful life with gratitude and achievement. He has also published an eating disorder supplement to the book that he shares with clinicians at no charge. Email requests for a free copy can be sent to drdbucketlist@gmail.com. Additionally, with his extensive experience as a physician, neuropsychiatrist, psychotherapist, and psychopharmacologist, he has supported, inspired, and aided a multitude of individuals with a variety of mental health conditions on their healing path. Dr. DeSarbo specializes in treating patients with eating disorders, and we are absolutely thrilled to have him join us here today. Welcome, Dr. DeSarbo.
Oh, hi. Thank you very much, Linda, Jack, and Ellen. And I just want to let you know that we may talk about it later, but if clinicians do want a free copy of the eating disorder supplement, the actual email is drdbucketlist.com. So it's DRD. Bucketlist.com for that free copy, which is really intended for clinicians, but I felt was an important piece of information to get out that I just didn't even want people to pay for.
Yeah, and how many copies have you given away now? I think it was 1,500.
I thought when I initially put out some of the announcements on social media, I'd give out a couple hundred, but it's been 1,500 copies that I've given out internationally too, which is, and I'd say half of those, if not more, are actually clinicians across the world who have requested copies. And for me, that's very encouraging to see people want to continue to learn from advances and get additional knowledge in the field.
I think it's incredibly important that you're offering it at no cost. The information needs to be shared, and that it's available on a global basis, because certainly this is a global issue. And as much as we're not necessarily where we want to be on a global basis, it's really frightening. Anyways, welcome, Dr. DeSarbo. We are so honored to have you here with us today. I've heard so much about you. I've thoroughly enjoyed getting to know you from reading about you, and I'm so excited to learn more, to open a real conversation. It's so refreshing that you are who you are and having the conversations that you are having.
Well, again, welcome, Dr. DeSarbo. And again, I think I connected with you on LinkedIn back in 2019, or it was right after we wrote our book. And I am so glad we've kept this connection, and all the work you're doing is just so wonderful and so needed. What made you decide to offer up this type of a conversation?
Well, I think it's having been in this field for quite a while now. After a couple of decades of practice, I've been working on figuring out my own purpose in life, if you will. And at this point in my life, I feel it's important to be open and honest. In the beginning of anyone's career, even my own, it's common. You go out in the network at conferences, you meet people in the industry, you try to build a practice. So there's a lot of niceties in this networking. And, you don't want to offend anyone, or it could affect referrals. People worry about this, whether that's an individual or big residential facilities. And before I was in medicine, I was in this business world, which I never felt particularly comfortable with. I played the networking game, and I didn't care for it. So when I went to eating disorder conferences, my motives were always to meet people I could learn from, and more importantly, respect. Who did I respect? And to that end, I formed many great bonds with top experts in the field, and I'm deeply grateful for that. But I was also privy to a lot of inside information on the business side of eating disorder treatment, which was probably more transparent to me as I had that business background. But I still played and walked on that eggshell game at times, not wanting to upset the accepted balance all along. But now I'm older in life. I'm at a point in my career where I feel I have been at such an independent place in my practice. I have no sense of obligations to the business side of networking, and that's freed me to talk openly when working with patients, families, giving them advice for the best pathways, places for care. I don't have to rely on treatment center or individual clinicians to refer me patients, so I can be more open and honest in my decisions and recommendations and what I've learned over all these years. It's been tremendously liberating, and because I'm acting life more as a physician should act, working on behalf of my patients without concerns of any network fallout or business fallout. So essentially, I thought, okay, now's the time for me. I used to always say, I always wanted to write this book on, the truth behind therapy in general, because everyone else, with everyone else it's different from a typical medical model, and people are trying to walk, say the right things, not offend anyone. And I'm not out here to offend or attack anyone, just to be open and honest. But that's something I feel, has been limited in all of these types of talks and, discussions. So I'm here to really gently tell the truth from my own experiences. So certainly these are my experiences, but they're based on what I've learned over decades.
That's beautiful.
That's beautiful. Yeah, wonderful.
Can you tell us what changes you notice in the evolution of eating disorder treatment across the different levels of care, among treatment professionals, treatment centers, and with the growth of virtual care?
Oh yeah, I mean it's changing rapidly. The eating disorder treatment, it's increasingly shifted from a couple of decades ago, where it was very clinically driven, to more of a business model, financially driven level of care in many instances. A little over a decade ago, most treatment centers were privately owned, and the founders' reputations were on the line. So they placed more emphasis on the quality of care than profits. However, treatment was more expensive. And when you hire experienced clinicians, and insurance companies would fight tooth and nail to pay for claims, and they still do. But business investors saw an opportunity to cut costs, attract insurance companies, offer lower daily fees, enhance profits. So this new model took place. And it has worked on a business model. And many treatment centers are now owned by venture capital or private equity, which has had an effect. And it's fundamentally changing priorities from my perspective, from being patient-centered outcomes to scalability and margins and utilization. So treatment centers often now are much more standardized in their care. It's replaced clinical judgment as more following manualized, insurance-friendly protocols where it's more of a one-size-fits-all model, regardless of diagnosis severity, neurobiology, comorbidities. And the rules sometimes, because of that, become more punitive. I hear more and more from patients complaining of how their experiences at some places, not all, feel more punitive, compliance-focused. And patients sometimes feel more that this is causing more shame and more dehumanizing, which really upsets me because, it's something that I didn't used to see or hear as much. So there's shortened lengths of stays that's driven by insurance. Clinicians, they rely on less experienced clinicians who are kind of trained through models. They come out of college, and it's great training to go into a treatment center and learn about eating disorders. But, it's, again, becoming more treatment model-based, following the manual and the book. Whereas when it was more privately owned, you had a lot of places had more higher level of care physicians. So there's more acuity and lower levels of care due to cost pressures, medical instability, and it's when we talk about eating disorders, they're malnutrition-driven brain dysfunctions, and that is something that people tend to learn and understand later in their career. So there's these gaps that take place, so there's consequences to it. But you asked me a big question, I feel, we can get into also, if you want, where we're headed. Since COVID hit, dramatic changes. I wrote a paper recently on how we need to use more caution with virtual care, because it was never researched and studied as what's the best approach. So much like any Zoom call or Doxy call or FaceTime call, we're only seeing a limited part of a person, as when we used to have people come into offices. And I saw the most fascinating study just a day or two ago about how important it is to see people's hands in communication, which, look, we can look at each other right now. We don't see hands. And seeing someone's hands is a major factor of trust and trust building. And no one studied these transitions to virtual care right now. And it's been great in some instances that people have more access to it. Insurance companies have even decided to cover it this way. For some people, they're willing to go. But lately, I was talking to a group of people saying, if you really want to do virtual care, you should be seeing their entire body sitting in a chair, just like you see in an office. They should similarly be able to see you sitting that way. And there's research behind why that should take place. So, I don't know. I'm going on. Maybe you want to break that. You want to break that up into other types of questions, So.
Yeah. No, Ellen has a question, I think. Yeah.
Oh my gosh, question number one, and I have a million questions popping into my head. If you will please share how clinicians are trained, how research translates or fails to translate into practice, and how systemic and financial incentives can quietly shape the treatment model. All of these things you kind of touched on. So maybe if you can dig a little bit deeper. You mentioned many young clinicians come in right out of school in an eating disorder treatment center. And we all know they have not received a lot of baseline, a lot of prior training. So they're a blank slate, and which has its benefits and its disadvantages.
Right. Yeah, and like I said, the benefits are for the clinician. There's great benefits because if some of these clinicians who begin in getting their treatment in hospitalization care and residential and higher levels of care, they get to see a tremendous amount of patients. Hopefully they have a good supervisor who's kind of guiding them. But the nuances that are acquired over decades aren't always there. So if you back all the way up, first exposure to eating disorder conditions and treatment is very limited in the academic arena traditionally for all clinicians, physicians, psychiatrists, therapists, nutritionists. You can learn about eating disorders in books and in a classroom, and there are very few fellowships in our country for psychiatrists, physicians, therapists. But so people have to actively go out and seek that additional training and hands-on experience for a period of time through programs like getting it's called a Certified Eating Disorder Specialist certification through IADEPT, one of the major organizations. And this is a great program that's offered through IADEPT, yet there's a limited amount of people who actually seek that out. There are people who do it, but compared to the number who say they practice, they don't have that said certification, which is kind of like an alternative to having a fellowship, but it costs money to go through that and have supervision. So a lot of people don't do that. And they learn to follow protocols, not to understand why they work or don't. They're just given these books and kind of supervised in certain settings with a lot of detail. Now, even for myself, I always say nothing beats learning about an eating disorder than working with patients. You can't learn it in a book or lectures and everything. You have to see it with an open mind, with additional training. So again, on the same, with all this training, there has been advances. I'm not all on the downside with this. We can recognize early eating disorders earlier than we used to. There's a broader awareness. I do think some things like social media, the right social media has helped increase awareness, has helped people learn more about what's out there. Again, the telehealth has expanded reach for underserved areas. And there is even now, like I said, with all the requests that I had for my books, there is growing recognition that eating disorders are these brain-based illnesses. They're not choices. And I think what I'm really happy to see is whenever somebody like a therapist or a nutritionist says, can I get this book? Because I want to understand the neurobiological aspects, that kind of makes me feel good inside. But
the one thing I've seen, it gives me some hope, is that there's a lot of people that have come through their own journey, of an eating disorder, and they're in their own recovery, whatever that is for them. And now they want to give back. So they are going and being trained as a clinician, a dietitian, therapist, whatever. Right. And because they understand, what the other, more so what the other person's going through. So yeah, I see a lot of young people coming into the field that have suffered themselves.
And even people like, I just wrote an introduction to a book. I have a colleague friend in New Zealand. She wrote this book called Mad Food, The Nutritional Neuroscience of the Starved Brain. And it just came out. But it really, this was a nutritional book that really talked about what I would describe as how food is the medication, how it works from a neuroscience perspective, and I think patients need to know that information.
Bravo. Right. Can we stop and have a drum roll?
But
yes.
Can I just follow up to that? Because I saw somebody on Facebook that posted that book, and she's a clinician. And they talk about, getting weight restoration higher, higher and faster.
Sooner.
Yeah. And
right.
Some of many of our people in our groups and stuff, and other people we've just talked to, said that can be very traumatic for somebody, to weight restore too soon, too fast, I should say, because it changes their body and
Discomfort.
Yeah, and discomfort. Yeah,
Well,
medically discomfort.
Well, a lot of that's, again, being driven from the business side.
Yeah.
Dollars
being
and
driven
cents.
from the insurance
Yes.
companies.
Correct. Yeah.
However, here's the thing. Weight restoration does not equal brain recovery. It does not equal eating disorder recovery. You can't, again, go too fast. It's not just, like you said, psychologically challenging and damaging. It can be, physically
Right.
challenging and damaging. It needs to be an appropriate balance. Not too fast, not too slow. Food is the medication, but it's still, the brain still recovers at its set scientific parameters of its ability to recover. It takes time to reestablish new neural pathways, neurogenesis, neuroplasticity. You can't, shove down extra food and speed up that process.
Well, you
And so many-
say it takes 6 months. I think you said.
I've always said that. It takes 6 months for us to start to get some new wiring. It takes another year for that to kind of solidify. That's if everything goes right. Smoothly, which is not usually the pathway.
Right.
And so many of these patients have GI issues. And, even if you've been sick and had the flu and have to eat again, it takes you a while. But if you have real, GI issues, long-standing, I'm sure it has to be delicately dealt with and gradual, much more gradual for them. Yeah.
Yeah, and understood. Like when we talk about the GI tract, we have more serotonin and dopamine receptors in our gastrointestinal tract than we do in our brain and central nervous system. At the same time, there's the study on microbiome, our gut bacteria, is really in its infancy. But, we have as much different and numbers of bacteria in our gut than we do cells in the human body, so and everyone's bacterial composition is different. And these are things that often have never been looked at or never considered in nutrition, in refeeding and recovery. But I do think, it's going to be those advances that will help eating disorder treatment down the line.
And what's your feeling? I mean, research is important, in all, whether it's mental illness, physical illness, whatever. But do you think research will ever filter down to clinicians, and will insurance companies pay attention to research that's being done, like the Angie study that was done, the EDGI study that's out there now?
They take a long time to disseminate, though. Yeah.
Well, this is where I feel research is going to rapidly expand. It's one of the positive aspects of artificial intelligence.
Okay.
I think we're going to be able to make great strides in biological interventions with eating disorders. It's just a matter of who adapts these, what kind of regulations are around them. But even for myself, I've come across some new I'll call them out-of-the-box treatments, but I come across the studies of uses of things like oxytocin and everything to complement treatment and how that responds. And the access becomes more available and the studies become more available. So yeah, I know, Ellen, I think you mentioned like how the impact of artificial intelligence, this is something that I am deeply involved in studying. And I always encourage people to study artificial intelligence, but from a perspective of you have to listen to the leaders in that realm, okay? The people who are on the top of development. I'm working on a paper, and I'll just mention this. It's a paper that I feel, once again, if I release it, most people are going to hate me for releasing it. It all began with finding out, is AI going to place therapists? And here's the thing, people, no way, you can't. You can't miss the human touch. But the truth of the matter is, when people say that, they don't understand, because I know people who are developing these platforms already. If you ask AI, are you going to replace therapists and treatment? It'll say, oh no, AI is just going to work alongside and advance it. Okay, then I kind of followed up with, that sounds like a canned answer. Tell me the truth, because I know people who are developing, and it kind of gave me this mea culpa, like, well, yeah, it is probably going to replace therapists, but we can't really say that, because AI, it's going to be able to, like the cameras that we see now, it'll pick up on pupil dilation. It'll pick up on blood flow. It's going to pick up on all these things that therapists can't. It has access to every journal on eating disorders, psychiatry, psychology, every research paper, every study, It's, and then when superintelligence, which depending on which top leading expert you say, could be anywhere from 5 years to 7 years, that's going to make what we have in AI right now look like horse and carriage. It's like, so again, it's like plus not only that, people have 24/7 access. They'll pay $39 a month for all of that. And so there's going to be changes whether people like it or not. But I also think, aside from that, what it can potentially provide for research and treatments, I think is going to help in eating disorders as well as other, areas of medicine. So,
Okay.
So it is brave and thoughtful to begin honest discussions like this aimed at advocating for patients and families, even doing so challenging the comfortable narratives within the field. As parents of accomplished, wonderful adult daughters who were significantly affected both physically and mentally by anorexia nervosa, we feel that near the end of our daughters' lives, they were not adequately supported by the medical community. It's kind of like we felt like they wrote them off. And, there were some wonderful people along the way, but yeah. So
we were abandoned.
Yeah, that is the perfect word. So we would appreciate your perspective on this matter. And I know this is difficult.
Yeah, and it's hard because, there's a very individualized approach with that I've learned with the people I've gotten to know over the years, I know there's a lot of talk sometimes about, what is, even defining what is like a chronic eating disorder and everything. And there's a lot of, there's no consensus really on all of that. However, myself and the majority of people that I've worked with, like we always believe we fight to the end. I always feel there's this unspoken therapeutic nihilism that creeps in when recovery doesn't follow certain guidelines or results. And it seems like clinicians who treat only with expected guidelines, prescribing medications that are only within specific indications, only evidence-based, they kind of throw up their hands at times and in my opinion, have kind of run out of ideas. And then they begin to talk about palliative care, giving up. And the problem I have when this happens from a clinician in front of parents and in front of a patient, when you hear from this authority figure something like that, it just totally reinforces what the ed brain also wants to hear, which is, yeah, there's no hope for me. The ed brain's saying that all the time anyways. So when you hear a clinician talk about these things or a patient or family reads these things, it makes it all more, I told you I'm without hope. And there are clinicians though, like certainly, I would never be, talking about, giving up, palliative care in the field of eating disorders for me, and we could get in a whole nother discussion, is different than palliative care with cancer. It is not the same. And I can go to studies that have shown that people, a lot of people will define chronic and severe eating disorders, severe chronic as being no recovery or advancement in 7 years. But there's a big study I saw that there's people who've recovered at 11, 12, 14 years, even without treatment. And we're talking about 50, 60% of the people past that 7-year period, So, but when that talk starts to go out there to the individual suffering, and they don't like suffering, they don't want to have their eating disorder, but the pain is so great. That's where those thoughts of giving up and suicide and everything starts to set in. And, I when I deal with those chronic cases that I feel, okay, they may be stuck for a while here. That's where, and it kind of goes into that book that I kind of wrote. It's like trying to find a reason to continue to fight. And I always feel that's not something that has been in a structured way in therapeutic treatment. So the eating disorder supplement to the neuroscience of a bucket list is kind of like, I always say, there's clinicians that push people into recovery, the treatment itself, giving medications, doing therapy, following the meal plan, going to resident. We're trying to push a patient to recovery, but we need patients who have a reason to pull themselves through. And that can be extremely existential and individualized, but needs to be explored. If that can be found, it helps someone kind of endure the incredible pain and suffering. I think a major influence that helped me realize this is there's a book, Man's Search for Meaning by Viktor Frankl. And I know a lot of people have read that at some point.
Classic.
A psychiatrist in the Nazi concentration camps who, while he was there, he made observations and later wrote this book. And summarizing very basically, why did some people give up and just die right away while others endured such incredible pain and hardship? Which, again, to me, there's a parallel there. A patient going through treatment their mind is enduring incredible pain and hardships. So they have to have a reason to keep doing that. And that's what I think, the type of support that has kind of been missing by so many people, but needs to be put there. That's why I have this book. It's an ebook on Amazon for $4.99. I'm like, I don't need to make $1.50 on the sale of ebooks. I have a daytime job, and I've offered it. Now I sit there and I wonder, why isn't everybody just send me that? I'm not trying. It's not a gimmick. I'm not sending them spam or anything. It's like. But it's what I've learned, and, I just want that information out there.
Well, you have so much compassion, so much knowledge for your patients and families. And I think people underestimate how important the continuity of care is, how important the language that you use around somebody who has an eating disorder is, because what you say isn't always what they hear. And purpose. We all need purpose to keep moving forward. But just listening. I think their worlds get so small sometimes, and they get stuck in their own heads, and they just can't find their way out. And that small world makes it hard for people to experience a revelation if your world is so small.
Right.
So I just think that compassion, the skill of listening, working, it's in a team of professionals, and so few people get what they need as soon as they really need it, and that's frustrating. Right. It's frustrating. But I admire your honesty, your candor, and your level of compassion, and certainly your knowledge of the brain. So, and your willingness, just to share this information to help anyone who's struggling.
Our whole purpose, of the awareness, the education, and the connection of people and getting people is so they don't get to that point of having to make that decision. And unless
or that it's even a question of that. Right. Yeah.
So we need to change, like we've been talking about, change the treatment model. And so it's not so cookie cutter. So you're treating that individual, you're seeing that person beyond their eating disorder, and what's in there, and Emily early on, went for treatment. She knew she was going down this dark path. The eating disorder was taking over her life. And then, 6 days into it, an insurance company says, well, you're not sick enough for this treatment anymore. You've gained a couple pounds and your BMI is such and such. And, that was the time, that she really could have gotten well, and because she knew it. She knew what she needed. And came back so angry and embarrassed because she told everybody how sick she was.
They refused residential
and refused treatment here.
And they refused residential care and then outpatient care. And she told her colleagues, she was a medical professional, doctor of pharmacy herself. She told everybody she had anorexia, she was going away, and she had so much shame and stigma, and she said, well, I'm just not sick enough. And she threw herself back into work for 6 months. And, it got a little complicated and messy after that. She rallied back and forth for a while, but then basically, it took her. And your daughter, Ellen, was, accomplished, such a hard worker, worked right up until she passed away. Is that right?
Absolutely. I think when I said abandonment, it was exactly what you talked about, that there was none of this looking at who this person was and inspiring them to do the hard work. It was, you do it our way or adios. And so now that we see this shift happening, it is really, I hate to say exciting, it's hopeful. Maybe that's the word I need, that maybe things are going to shift, because the other thing that really resonated with me was when you said, it takes time. Well, it took 2 years in my daughter's experience to get to a catastrophic level. It was not going to take 2.5 weeks to get her ready to jump it back into life. And so it's these situations that we're talking about. And we also know that sometimes this is still happening.
Yeah.
And my question for you is this shift going to really catch momentum where we're looking at the patient? And I'm going to focus particularly on adult patients and help them understand what is happening to their body. Why? Give them that motivation. Remind them of the disconnect that happened. They don't remember who they are. Mm-hmm. They don't remember they're loved. They don't, and they also don't realize they could die.
Well, yeah, and also it's so challenging when somebody is an adult, very bright, independent, had been very successful, and got to do this on my own. I don't want this much help. It's very, very challenging for families to know how to.
Yeah. So give me hope.
Yes.
Well, first of all, I think when I part of the reason I wrote the eating disorder supplement to the neuroscience of a bucket list is I talked before about you have to find that intrinsic, personalized motivation, that existential reason for them to endure. And the one thing I can tell you over the years is the thought that they may die from their eating disorder or have mental, that is not usually the reason that will motivate them for treatment. So that's what I'm saying. My hope is, like, look, on the negative side first, I am not hopeful towards the business model of insurance companies. Okay, I see it even within the last couple of years. They are not in the business of helping patients. No. I'm sorry that they're in the it's a business. You collect payments and you try not to pay any out. But I do feel the hope comes from the individuals who are involved in the treatment. Because so many people who do go into this truly have great compassion. They're not. They're not motivated by the profits. They want to have that compassion. That's why I say, people who are reaching out saying, yeah, send me that free copy. If they're applying that, they're going to have better relationships with their patients. And I think, starting with the therapist, that's the strongest connection a patient can have, is that they can trust somebody who they feel understands them. They can say anything and they won't feel judged. They can talk about the pain of recovery where the therapist understands it and helps them feel motivated to endure the pain, because you're not going to lessen it when an eating disorder is at its full-blown height. And by that, of course, I'm referring to emotional pain. But now, if you have a nutritionist who is also developing that compassion and understands the neurobiological process, and you have physicians and psychiatrists So my hope for all of this is that the cultural shift is recentering treatment around biology, compassion with psychology, and helping a patient find more meaning to go through this. And that has to come from themselves. And even with this conversation, we have to normalize conversations to be honest. I will tell a patient from the first day I meet them, if we're going to do this, it's going to be extremely hard. It's going to be extremely difficult. But what I'm here to do, and the rest of the team treatment as well, is to support you through that pain, to help you figure out how do you endure that, to get yourself, because it'll be up and down. There'll be times that are harder. But as clinicians, we have to keep getting better saying, this isn't working, and it's not the patient's fault, okay? It's not the family's fault. And we can't be running, in my treatment, ED 180, I vote that's the 6 months jackets, right? It's like, if you're running a treatment plan and nothing has changed in 6 months or has deteriorated, you better be changing that treatment plan, whether it's the approach, the clinician, the level of care. It should not, after 6 months, be exactly the same. Now, I'm not saying it should be someone in partial recovery or anything. I'm just saying there should be a direction that's moving along. We have to continue learning from the best people, and I think we're going to be able to keep doing that. We have to understand, incorporate that neurobiological component, but I'm going back to, and this has been what I'm trying to share with people, is I feel one of the tools that I have that have helped me most in people that I've been able to work with, and I do some, I am the psychotherapist for a handful of patients. Not all of them. I'm more of the psychopharmacologist, but I'm not somebody who says just take this med. I need to know what's going on. We have to help that patient find that intrinsic motivation, and again, I think my hope lies in the continued compassion of people who do treat.
I have a little mini question, if I can please ask. What are your thoughts on the either family or loved ones, the support for the individual who you're working with? How do we get them where they need to be so that they truly can create support?
Well, I think the one thing is, the key word is support, okay? The family is not the treatment itself. Like I say, it's hard because somebody can say something to me, and my response to them could be the same exact words a parent may say. But when it comes from a parent, the ed voice is amplifying that as a judgment. So if I say, okay, you did this week, we need to kind of step it up, said from a parent, it's almost like a judgment. So you're saying I didn't do good enough. You don't understand how hard this is. So the parent has to be there as a supportive role. If somebody says what's the most important thing for support, is you support them with treatment. You support their treatment, it's not the family's fault, but I will say there is a situation where I'll say I blame the family. And that's that if your child is suffering and you do not go out there and get them the right treatment, I'm sorry, but now it's not always their fault because they may not understand it themselves. Right? Like we're always saying, you want a nutritionist, make sure your nutritionist truly does understand the eating disorders, not just, no, I know a friend who does it, but so the most important thing a family do is not try to fix it, but listen, okay? And you have to listen without judgment, because, I was talking to a group of people the other day, and I was explaining, when someone sees themselves in a mirror and they can be severely anorexic and say, I look huge, I'm very fat, to say something like, but you're not, okay, that is really biologically like the person is seeing in this reflection, okay? And you're saying, no, you're not. It's going to be making the person with the eating disorder feel like you're lying to me, or you're not being honest with me, or you don't get me. And that causes the person to then pull away. So listening, not fixing, and I always say also, just that my little tip is never comment on appearance. Someone walks out and says, "How's this dress?" Even that's a trick question. How do I look today? You look healthier. That's, we all know in the field, that means you look fatter. It's like, so I always say, you say, well, you look like you're a little happier today. You can go back to the emotions, or you look like you're upset, but the parent's role is to be supportive, but not the clinician.
Yeah.
Did I answer that okay for you, Ella?
Thank you very, very much.
And everybody's journey is, the patient is different, and the parent, every journey, with the parent is different. Some parents, after 6 months or a year, they're tired and they're frustrated, and they, how long is this go? When's this going to stop? And we've heard that. And then there's parents that have been dealing with it for 20 or 30 years, and they're older now, and they're tired, and now they're in their 60s or 70s, and they're still dealing with this, and it's exhausting, and
in my training as a resident, I was fortunate enough to have as my residency director two early pioneers in the field, Dr. Jack Yatz, Dr. McMurray. And I remember them saying to me, the thing with an eating disorder is an eating disorder consumes the patient consumes the family.
Say that one more time. The eating disorder.
An eating disorder consumes the patient, and the patient consumes the family.
Oh, okay.
So it's that interesting thing in psychiatric that, the severity, the complexity, the mystery behind it, it's not just isolated to that individual. The whole family feels it.
Mm-hmm. Where can people reach you if they have questions?
Well, I wish I could say out in the Mediterranean. But, so I have a little, I have my treatment centers, ED180 treatment programs, and that's at ed-180.com. My Dr. DeSarbo personal website is DeSarbo, DeSarbo.com. The bucket list is kind of this off take from everything I do. I post articles, and I strongly encourage people with or without eating disorders to read the articles. I call them infotaining, and that's at bucketlistdoctor, DOCTOR.com. So I have those three websites. My email address personally is Dr. DeSarbo at Gmail, DRDESARBO at Gmail. And one thing I always like to reference people, if they really want to say, who's this guy? What's he really about? How does his brain think neurobiologically? If they go to YouTube and you just put in DeSarbo and eating disorders, I have a whole neuro series. It's a 15-part series. I put it out when COVID was out because I was stuck in my house, and the patient said, "Can you please put all this talk on the internet for my dad to see?" And so I strongly would say, go to YouTube, watch these little 20-minute, 15-section videos. You can pick on certain topics and everything, but I'm usually addressing it from that unique neurobiological perspective in a manner that I think most people can understand. So
it's a treasure trove.
Oh, I have listened to them all, and I highly, highly recommend that people go out and listen to them, because, a couple of them I've listened to twice, because it's, and there's the one for families is wonderful that's out there. So, thank you so much for doing that. And again, this is all free stuff, that you can learn from. It's so enlightening, and so thank you.
Your book, The Neuroscience of a Bucket List, is for anyone, right? The supplement is for eating disorders, and it's marvelous, and I highly recommend it for anybody who works with eating disorder patients. But tell us a little bit about your bucket list book in general, and how it is for everybody, and why you wrote it to begin with.
Well, ultimately, what motivated me was two things. One is I feel we need a counterbalance to life today. It's chaos, it's hectic. I talk all the time about in the past 5 years, there's certain conditions that have been rampantly coming in. Anxiety, OCD, ARFID is a big one that suddenly seems to be spiking. Illness, anxiety, and people are really on edge, and so the bucketlistdoctor.com supports the book. The book is really kind of a structured way where it's a system, okay? It's not like this magical thing. It's not like, oh, the movie, let's just, take fancy vacations or go skydiving. You can put that on your bucket list. But what I talk about is the importance of kind of shifting the brain's focus by creating these goals, again, for all of us to find what's important to us, what's intrinsic to us, what's meaningful, that helps us have a purpose. Even for patients, when we work with eating disorder, it's right. Control is an issue. When you make your own bucket list, deciding things you want to do in life, and there's all kinds of categories: giving back, mindfulness, travel can be there, family, legacy. I have hundreds of categories and hundreds of things that they can think about. It rewires our brain. So what's unique about my book is I talk about when you live thinking this way, novelty. I'm encouraging that all the time. Always keep doing new things. Do new things out of your comfort zone. A year ago, I took acting lessons. I'm not trying to be an actor. I just saw a flyer somewhere. It's there's a movie, Yes Man. I just picked off the flyer and said, all right, sign me up. Because my brain's never done that. And when you do that, you do start to wire your brain. Especially after the age of 40, our brain changes. We produce less of the important neurochemicals. But when you live kind of like following this structure of a bucket list, it has almost an anti-aging effect. It keeps us young. It keeps us cognitively focused and sharp. And so I think that's something that, I honestly have to say, every single person that has read the book and came back to me, if you read it, look, if you go on Amazon, read the first chapter 2, you'll probably say, I'm going to do something different tomorrow. It really starts to change how you approach life. So, so that book is written. It's written for, 15-year-olds, 50-year-olds, 80-year-olds, The supplement kind of says, well, how do you use this technique when working with eating disorder patients? Mm-hmm. Because it's not, make a bucket list, put all the things you want. No, it's about finding intrinsic meaning, purpose. It answers those really importance that I think in today's day and world mean more than ever for us to kind of manage our stress and mental health.
Yeah.
It's wonderful. It was very uplifting, and the backstory behind it I loved too.
Right. That's highly. This was really inspired. My father taught me this. I remember when I was a doctor, I was looking to buy a house. He goes, "Don't put all your money in a house. There's a lot in this world to see and experience." Those words changed my life forever. And because of that, when you live kind of doing more of the things in life that you really want to do while we have our time on this planet, it does lower anxiety. It does make us feel more grateful. Like I said, when I started giving that book away, and now 15, maybe I'm close to 1,600 copies now, I can't tell you inside of me how that's changed me. Where I really, I'm working on another eating disorder book. And I'm like, I should just give this one away. It's not what I do for a living. And then when I do that, I go, listen, any clinicians who are writing a book and hear this, do you really need the extra small income from a book? Because I want to set an example here. Clinicians in our field, you want to make a difference and feel real good? Give a version where you can just give it away to people who are going to take what you have. Like I always say, if a bus hits me today, it's gone. That information in my head's gone. Well, how's it going to help people? How's it going to help our field moving forward? But if I can put it in writing and get it out to people, I'm hoping the generations that take that not only learn and apply it, expand upon these ideas. And that's how internally, I feel good that, something like this may happen.
So can you send that to all the insurance companies out there too? So that they understand. You're not going through the frustrations of trying to get coverage and trying to get payment and try.
No. It's that's where again my unfiltered bad side comes out, and I'm sure maybe I am holding back a bit because I don't feel like being assassinated tomorrow by an insurance company. So.
Oh, wow. This has been wonderful. Any closing thoughts?
Well, I have a thought. I think the three of us sitting here and who, went through the most devastating thing of losing a child to this, wish that we had known you years ago and our daughters would have known you years ago. So.
Oh, my God, yes. I say, we tried to learn everything we could all along the way, but at the beginning, nobody was really talking about eating disorders, And I will say that at least now, there's more people affected by mental health issues, which is the downside. But the good part is that we're talking about it, and there's more information out there. And, the love was always there. She tried her best. I know she did. We tried our best. But there are dozens of things I would do different and that we would do different, and a million just the same. But I'm so grateful that we knew it wasn't a choice, and we did learn a lot early on, but there's just always so much more to learn. And I love that you always say nowadays there's more things to try than there were when our daughters were younger. And I think that sense of hope is so important, and just very grateful for you and your message and spending this time with us today.
Yeah. And when you said earlier, about, it's not the parent's job to fix it, as a dad, when you have children, it's the dad's job to fix everything, make things better and stuff, right? And, but Emily at the end said, Dad, you couldn't fix it, she told me.
But that's where the parents hurt inside, because, right, we always think we want to. And I do want to say, final word from Maya is, it is not a cliche to say what you're doing is extending her memory and growing. This is a true reality from my perspective. She is living through you with your words today. In a way, like her eating disorder, it was a sacrifice, but I cannot, and I'm saying this truly, the work that you have done with this has probably saved so many lives. And I mean that.
Well, and
that's her too, your daughter and you guys. Yes, you had your loss, but you did something that I have no doubt you're saving lives, that you're turning things around for many people.
Well, thank you.
That helps one person, right? So
yeah, and I know we have helped one person, for sure. That's
well, it's hard to have the whole story out there sometimes, but because a lot of people still won't get it. But God bless the people that do and that reach out. And Ellen, I know,
and that's our core belief.
Yeah,
we lived it. And we knew by that experience, we knew we had to say, wait a minute. Can we look at this a little deeper? Can we start the conversation? Can we also get honest? Can we be real and address some of the real issues? And I loved at the beginning when you mentioned that there is an element where you have to do a little bit of a dance because you don't want to offend and you don't want to.
Right.
And that is so true and so pervasive. And I think we really need to get a little more real.
I'm always here to be open and honest. I'm not worried about any life and career. So if you ever need to reach out, just do so.
God bless
and
you.
I'm seeing more and more people from around the world, in the UK and in Canada, that are opening up and saying how frustrated they are with the way things are done and continue to be done. And so there's changes are coming. We wanted them yesterday, but we'll just keep working hard. And
thank you so much.
Absolutely.
And we extend our sincere gratitude to you, Dr. DeSarbo, and to, of course, our listeners. Thank you for hanging in here with us and being so supportive. A big shout out to Rock Vox Recording and Production and Scott Fitzgerald, our remarkable sound engineer, for his exceptional production of our podcast and so much more.
Check out Dr. DeSarbo's book, The Neuroscience of Bucket List, Getting the Most from Your Brain in Life, available on Amazon. Please rate, review, share, and subscribe to this podcast. Once shattered, picking up the pieces on the platform you are listening on. Learn more about Linda and Jack Mazer, the founders of the Emily Connection, and their beautiful book, Emily, the story of a girl and her family hijacked by anorexia, available on Amazon.
And thanks to our wonderful, wonderful co-host, our colorful co-host, Ellen Bennett, who over 25 years of lived experience, community engagement, and advocacy has raised the awareness and the challenges and the stigma associated with eating disorders and all mental health. And the discussions we have here with all our guests are incredibly important, as they always emphasize the importance of mental health for every one of us. So thank you, listeners.